Right. Good morning, everyone. Let's wait for the others to join, okay? You are the light of my heart, desire of my life, sweetness to my soul. Jesus, my Lord, you are sweetness to my soul. You are the melody in my heart. Okay. Let's wait for the others to join. Okay. Oh, you know. Jesus, my all in all. Melody in my heart, desire of my life, sweetness to my soul. Let's give ourselves some 3 minutes for others to join. If today is your first time you joined, you are welcome. Okay. Okay. You are Jesus, my soul. Jesus, my Are you ready? Greetings from my end. Wow, thank you so much, Juliet. Mrs. Everest, thank you so much. One day you take me to Mount Everest, okay? And we are all welcomed to this noble group. I hope you had a good day. Right. G, G, G. Are we ready? Can we start? Can we start? Are we ready? Yes, we can start. Okay, so today we are starting with basic care and comfort. Okay, basic care and comfort. So it is something that I want you to take note of. Okay, basic care and comfort. Basic care and comfort. Okay, give me 2 seconds. Let me sort this thing out quick. Okay, right, right. 2 seconds, I'm coming. Okay, so let's continue. Sorry. Today is Thursday, 13th of August. And as you all know, we have decided to start our day, our seminar on basic care and comfort today. So I've promised you that we can use 1 month to 1.5 months to prepare for the Nclex. Get you ready. You move with confidence, you get your exams, you pass and go. So once you're on this platform, forget about failure until you don't want to learn. Okay, until you don't want to learn. If only you want to learn, then be ready for success. Okay, yes. And I will teach you on my platform. I teach only curriculum. I don't waste time on other stuffs. Okay. Sometimes we join to learn about opportunities also, opportunities that can also help you to succeed in life, okay, to direct your path. Yeah, so you get along and you stay committed and make sure you become a successful person. Okay. We are still learning, we are still teaching you guys to become a better person in future. Okay. I'm not going to waste time. Let's start. Let me share the screen. Then quickly we start. Okay. Yes. So basic care and comfort. Basic care and comfort. Right. So after everything, I have some questions for you to answer. So don't worry. You're gonna answer them. Okay. But this is the seminar. That is the seminar. Okay. It's a lot. Basic care and comfort is a lot. It's not going to be a rush. Okay. It's not going to be a rush, but we will make sure we go through everything and make sure that everything also becomes successful. Okay. Yeah. So when we say basic care and comfort, yesterday I was trying to explain some things to you. Okay. The basic care, everybody deserves a care. Everybody undergoes. You woke up in the morning, at least you brush your teeth. You have some people have bathed, some people have made their hairs, comb their hair. Some people wear clothes. You have moved from your bed to outside your bed. Some have walked, some are still in bed. Okay. So all these are the basic needs every human being or every living being requires. Okay. And that will make you comfortable. Okay. If you are sick, you need a care. Somebody must do it for you. But you also have to do some aspect as well. Okay. Yes. If you are dying, somebody must still ensure your basic care is done for you. Okay. Yeah. So these are the things I want us to go through today. Okay. These are the things I want us to go through today. Okay. Right. So let's look at the concepts. Can the nurse safely meet the patient's needs? Okay. Can you safely meet the patient's needs? 2 seconds. Can you hear me? Can you hear me, guys? If you can hear me, let me know. Let me know in the chat box if you can hear me. Okay. Okay, good. Right. Okay. So can the nurse safely meet the patient's basic needs or physical needs, maintain comfort, preserve function, and prevent complications? That's the biggest question, the central question to basic care and comfort. For example, okay, we are going to look at these areas, activities of daily living. So before somebody writes Nclex, you know, or any other nursing exam, when we talk about activities of daily living, bathing, grooming, dressing, feeding, toileting, the oral care. So the question is, can you help me or can you help a patient to bath? Okay, maintain their comfort, preserve their body function, and prevent complications. Can you take a patient to the bathroom and come back without patient falling? Okay. Is it even right for you to take the patient? Are you allowed to take the patient to the bathroom? Imagine the security officer comes to the ward and says he wants to help. He wants to take a high risk for patient to the bathroom to bath the patient. Okay. Is the security person trained? Is he trained for that? Does he have the required training? All these things are the things we are going to learn. Nclex is not going to teach you how to bath a patient. No, they are looking at the safety aspect of it. Okay, you are grooming somebody, you are wearing clothes, the person has an injured arm. Okay, how are you supposed to wear the clothes so that you not cause any complication? That is what Nclex is looking at. Okay, you are dressing a patient, you are feeding a patient, It's not only about the food. Can the patient eat the food? That is one. Can they swallow without any complication, without any aspiration, toileting needs, and all those stuff? Then we go to mobility, assistive devices, how to use walkers, canes, crutches on a flat land, on a staircase, moving up and down, okay, transferring the patient from bed to chair and chair to bed. What are the safety aspects, issues around them? Then using prosthesis, okay, nutrition, feeding assistance. Can the patient feed themselves? If they can't feed themselves, are you going to help them to feed? Okay. Are you have you been trained on how to feed a stroke patient or a patient with neurological deficit? Okay, a patient with cancer of the throat, you are helping the patient to feed. Have you been trained to do that? That is one. Two, the nurse is supposed to delegate somebody because the nurse cannot do everything. Okay, is the patient stable? That patient you are giving to the healthcare assistant, is the patient stable that the healthcare assistant can, or a kind of patient with high risk, unstable patient? Is it right for the nurse to delegate for a newcomer, a healthcare assistant who just started work to do that job? So all these things are the things we are going to look at. Therapeutic diet. What type of diet is good for this patient? We all cannot eat the same food on the menu for morning shift. No, every patient has their own food therapeutically. So the nurse must know all of them. Patient A eats this food. Patient B eats solid. Patient 3 eats liquid food. Patient 4 eats soft diet and bite size. Okay. Patient, whatever, they have to put in thickener. Uh-huh. Entra feeding and all these peg feed, the NG tube, the orogastric tube feeding, the jejunoscopy or the IJ tube feedings. All these ones are there. Elimination. So somebody you eliminate, urinate and move the bowel. You are treating a patient with spinal cord injury. Okay. Spinal cord injury. You are treating a patient with spinal cord injury. This patient has constipation. Okay, who is going to help the patient to relieve the constipation? Is the nurse delegating the patient or not? Is the patient stable or not? Patient is not having urine retention. He is back from the theater, urine retention. What is the nurse doing? Okay, so these are the safety aspects we are going to. Then comfort measure. So comfort, pain relief. Somebody is dying, somebody is in stress. Sickle cell patient has come to your ward. They need comfort care. So the comfort relief, the non-pharmacological or non-pain interventions, sleep and rest, environmental fact comfort. Okay. Then we look at the skin. So we if today we will end at elimination if only we are fast. Okay, then tomorrow or tomorrow next. Okay, tomorrow I might not be around, but tomorrow Saturday we will do comfort measures. Okay, from 6 we will do skin. So we learn all the layers of the skin. Okay, and the what and what to do, how to grade a wound, how to reposition someone so that the skin does not break, the moisture, the management, the nutrition, and the skin assessment. Yes. Then personal hygiene. So oral care. A patient who has been intubated, patient who is unconscious, how to do oral care. Are you to pour water in their mouth or not? So all these things are the basic care. It looks simple, but it's not simple like that. There are rules that you must follow in order so that when they give you the Nclex question, you will not fumble. Positioning, the various types of positions is more than this. We are looking at every procedure and the position. The question you ask yourself before you position a patient, you will learn all those ones. Okay. Rest and sleep. So rest and sleep, sleep promotion, clustering care so that you don't interrupt the patient's sleep. Okay. The patient who cannot sleep, can we give some melatonin or what? So all these ones are there. Environmental modifications, then sensory and physical. So the five senses: the sense of sight, sense of smell, hearing. So sight, somebody have issues with sight, so they wear glasses. Okay, how are you going to take care of the patient's glasses when they are going to sleep? Somebody has what? Hearing aid. How are you going to manage the hearing aid when you are taking the patient to the bathroom? So all these things are what basic care and comfort that you need to know. Okay. Heat. Somebody heat, and those who will be working on the orthopedic unit. So heat application and cold compress. Okay, is it right to use it when the person is having sensory and motor dysfunction, especially senses? Because there are some people with neurological deficit. When you touch them, they can't even feel. So if you go and apply heat to their skin, and that heat is burning their skin, giving them burns, can they feel? No. So all these things you should know. There are safety issues that Nclex is saying you should know. Okay, they will ask you a question. Post-mortem. Okay, the respectful care of the deaf and the dying. Okay, the should the family be around or not? Family are saying they don't want you to call the organ donation people, but the country's laws also says that everybody who dies, if you don't opt out and you die, we need to donate your organs to the organ bank, so that when somebody needs a transplant, we can take it. But the family is saying no. What would the nurse know? What would the nurse do? Ethical dilemmas or professional dilemmas. So all these things comes into play. Okay, a patient is dying. The family members know they are dying. They say they will not come to the hospital. Take care of them. When the patient dies, call us and tell us we are okay. They will tell you that they want this funeral planner, the mortuary guy, to come and take this patient to the morgue and do the funeral preparations, everything for them. Family doesn't want to be involved. What would the nurse do? What are the safety aspects? Okay, the belongings of the patient who is dying, and the cultural considerations. Okay, the Muslims want their dead person to be buried today, but the hospital is saying that because this patient came as a coronary patient, we have to keep the body for what? Autopsy. There is a hospital and a religious conflict. The nurse is standing in between these two. Okay, what is the nurse doing to solve these issues? So all these ones are basic care and comfort. Okay, basic care and comfort. Okay, so we will go through, we will do our best, not a rush. Okay, all the space are for us. I told you I'm off till next week Thursday. So not a rush. The concept is that by the time we finish this course, you don't have to waste your time to pick the slide again. You should know your left from right. That is what I want you to know. Okay. By the time we finish this course, you should know your left from right. That is what I want you to know. Okay. Yeah. So, 2 seconds. Let's start. Why does basic care and comfort really test? Oh, okay. Or what does it really test? Why should we be more worried than nurses want to learn? Okay, many candidates or many Nclex students, they seek basic care and comfort and assume the question will be easy. Okay, they think you are just going to give bath, you are going to brush a patient, change the bed, feed the patient, help the patient to use the toilet. But Nclex is looking beyond that. Can the nurse meet the basic needs while maintaining safety, dignity, independence, function, and comfort? And also, can the nurse recognize when a seemingly or always The routine care you always do for a patient, can the nurse recognize that for today, if I take this patient to the bathroom, as I have been doing always, is it dangerous for the patient and for my profession? Okay. Can the nurse recognize that you always take the patient to the bathroom, to the toilet, to the washroom? Yes, nothing happens. But today, you realize that no, if I try, the patient might die or collapse on the way. Will you still do because it's a routine care? No. So the question that appears to be about bathing may actually test. It can test orthostatic hypotension. Yes, it can test that, but you will not know. Okay. The question about oral care, you always help somebody to do oral care. Okay. Today, you realize that no, if I try, the patient might have aspiration. Should I start or should I do? Or I should call the nurse to come and reassess if I'm a healthcare assistant or LPN. Okay. As for the nurse, you don't have anyone to call apart from the doctor. A question about toileting may actually test falls. That is how Nclex goes. Okay. When you see Nclex questioning you about dressing a patient, then they are looking at what? Neurological impairment. Okay. If you see a question testing about hygiene for a patient, then they are looking for what? Delegation. So the nurse must know whom to delegate the patient to. Okay. So the Nclex is what? This is the Nclex mindset for this section. This is the Nclex mindset. Okay. We have started though. So remember, activities of daily living, part one, ADLs. ADLs, we know, is the basic activities necessary for everyday functioning. Common ones are here: grooming, eating, feeding, and those ones. But we have ADLs and IADLs. Maybe today is your first time you are hearing this. Okay, yes, ADL, activities of daily living, everybody knows. But we have another type we call the IADLs. What does it say? Never confuse yourself that ADL with instrumental activity are the same. No. IADLs are more complex activities required for independent community living, such as managing medications, preparing meals, shopping, transportation, housekeeping, and managing finances. Yes. So the patient who has had a surgery of the hip, okay, cannot walk, requires what? A wheelchair to be moving around. They are conscious, they communicate, they talk, okay. But these people, we will program a special kind of support for them. We call the IADL. They are what? Instrumental activities that will help them with their activities of daily living. So you realize that most of you people who are in abroad, you do it, especially those who do home care. You go to this patient home, the patient can do most of their things. They can, when you take them to the bathroom, they can bath themselves. When you wheel them to the washroom, they can brush their own teeth. But they need you to support them, little support. We call them instrumental activities. So, such as what? Their medications, help them to book it, okay? Help them to go and collect it from the pharmacy and bring it home. Some people go to people's house to prepare meals for them, then they go home. Okay. Some people also go and do shopping for some patients, then they go home. Some also go and do transportation, take them to hospital appointment, bring them back home. That's it. You are done. A lot of this seminar is a community seminar that everybody should have listened. Okay. Because it is going to help everyone. It's not only for exams. Then housekeeping and managing finances. Somebody will give you a check, go to the bank, withdraw money for me. Okay, so these are the things you have to what know. Okay, these are the things you okay. These are the things you have to know. Okay, perfect. So a patient who cannot shop independently but can bath, dress, eat, and do toilet needs independently has impairment in what? Instrumental activities. You and I, we can do our normal ADLs and we can also do our instrumental. I drive myself and nobody drives me. Okay. Yes. So you do everything yourself. Okay. The golden principle is that with basic care and comfort, independence will always come before dependence. So do not do for the patient what the patient can safely do for themselves. Never try that. You are limiting the independence. Never try that. Okay. Yes, especially we from Africans, we are too generous that everything we want to help. Everything we want to help. Okay. No, the white person doesn't see it that way. The white person sees that you are what? Taking his independence from him. Okay, so you have to assess to know, can you do this? Are you able to do this by yourself? Are you sure you can walk by yourself? Okay, you can walk, but when I give you a walker, you can walk well. So I'll give you a walker. I will not carry you in a wheelchair and take you. No, I'm limiting independence. Okay, so before you do basic care, always what? Access for independence. Why are we concerned about this? Because we are promoting independence. Promoting independence help preserve the muscle strength, coordination, range of motion, self-esteem of the patient, autonomy, functional ability, and rehab progress. You can't be employed at a rehab unit and you are always doing things for everybody. 100%. No, we are not promoting independence. Okay. So more nursing assistance is not automatically better nursing care. Don't overdo for people. That's the important thing. Before helping, you always have to assess first. Before helping a patient get out of bed, shower, toilet, dress, or walk, determine whether the patient can tolerate this activity. That's very important. Okay. Yes. So in your assessment, you will know what you should be able to know the level of consciousness of the patient, the orientation, A no times 4, alert oriented times, place, person, whatever, okay, situation, and all those stuffs. Their muscle strength. You want to help somebody to the bathroom. Do they have the strength to walk? They are balancing. That is the vestibulocochlear. Okay, the vestibule. Balancing, that's the nervous function. Balancing. Okay. Yes, somebody can walk, but they don't have balance. They will fall. It's two things. Okay. The fact that the person was able to stand does not mean the person can walk. That is another thing you should know. Okay. Then mobility is another important thing. Pain, dizziness, false risks. Okay, false risks. Then oxygenation when indicated. Okay, the presence of IV lines, drains, and tubes. Then weight bearing restrictions. All these assessments you should do. Example: a post-operative patient says, "I want to take a shower. I want to take a shower." Eh? What is the Nclex mindset? Some students will say that, oh, they will choose this answer. The patient wants a shower, so I should help them shower. I should help them shower. Shall is what a compulsory verb. Now, whether the patient like it or not, I will shower the patient, especially those who work in care home. You take people's independence from them. Okay. You take their independence from them. The better option is that can this patient safely tolerate a shower? That is an assessment mindset. If the patient becomes dizzy on standing, safety takes priority over the patient's preference for a shower. So the mere fact that the patient told you, I want to take a shower, don't mean you should go and shower them. You have to assess before what you provide care. Okay, let's look at orthostatic hypotension. This is a major issue in basic care. So some patients who has been lying in bed for a long time should generally not be rapidly moved from supine to standing positions. Okay, they would develop what we call orthostatic hypotension, orthostatic symptoms. Okay, how will you know that somebody is having orthostatic symptoms? They will start having what? Dizziness, lightheadedness. Okay, if you are sleeping like this is your head, you are sleeping on bed. Okay, remember the veins will be sending a lot of blood to what? Your head. So let's say you have 1,000 ml of blood when you are okay. Now you got up and you are in an upright position or sitting position with your neck like this. These same veins that were sending 1,000 ml, they are now fighting against gravity to push that 1,000 ml to your head. So the highest they can do is sometimes 700 or 600 ml. Okay. You, the patient, or you, the person, you will feel that your head has become light. Your head has become light. We call it lightheadedness. Okay, lightheadedness. So it is a term in medicine. Weakness, blood vision, syncope, they will faint. So when a patient starts saying this, some of the patients don't talk. Some people don't talk in life. They bear anything they are going through. So you should ask them, please, are you feeling dizzy? Are you having any lightheadedness? Do you feel, they will ask you, what is the meaning of lightheadedness? Okay. Do you feel your head has become light suddenly? Light in weight. Okay. Are you having any blurred vision? Do you feel like passing out? Okay. And falls. Falls, everybody will see. So that one there, you don't have to ask them. Okay. So the safer progression with orthostatic hypotension, they lie, they sit, they dangle their hands and legs. Okay. Sometimes shake their body a little. They stand before they ambulate while assessing for what? Tolerance and balancing. So, example of a question, a patient who has been on a bed rest for several days sit on the edge of the bed and says, I feel dizzy. What should the nurse do? Don't continue because walking will improve circulation. No. Stop progression or stop walking and protect the patient from falling. That's the most important thing. So safety will always override what your care. Safety will always override your care. That is what you should know. Okay, let's look at bathing. Bathing as a concept. Nclex, no Nclex question will test you which soap is good to bath a patient, which water is good to know. Okay, they are looking at what bathing a patient, the purpose of it. Yes, everybody knows bathing removes dirt, sweat, and secretions. Bathing promotes comfort. It allows you to assess the skin. Remember, bathing is a skin assessment too. You have dirt on your skin. I use the water and the soap to bath you. Now the dirt is away. I'm seeing your skin. What is the nature of the skin? Is there a skin tear? Is there a bruise? These are the things you are watching for. It's an assessment, bathing. Eh? It stimulates what? Circulation, reduces odor. That can make the patient secure infection. Okay. It provides an opportunity to assess mobility. Yes. What does this point says? I am bathing you. Raise your hand. Patient will raise the hand. Okay. Raise this hand. Raise your head. Let me back you the back of your neck. This is mobility. So bathing is an assessment. It's not just I'm going to put water and soap off my body. No. You yourself, when you are bathing, assess yourself in the house. That you can't bend down again. Before you could bend down when the soap fall on the floor. But now you can't bend. What is happening? It's an assessment. You have a data, inform the nurse. If you are the nurse, assess the patient. Then it also what promotes psychological well-being. But bathing can create a risk. Okay, the patient will become tired. There can be pain with bathing. There can be hypothermia. There can be dizziness, falls, oxygen desaturation when you are bathing a patient. So when you see this risk, yes, patient is requesting for bathing, but I won't bath the patient. Okay. The bathing can cause hemodynamic intolerance, instability. Will you still carry the patient to the bathroom because you want to bath the patient? No. Or because the patient is smelling. So still I want to take the patient to the bathroom. No. The water you are going to use to bath the patient, what is the temperature of that water? It is going to cause hypothermia. So the nurse should individualize hygiene rather than assuming every hospitalized patient requires the same type of bath. Some patients will be bathed in the bathtub. Some will be taken to the hot bathroom. Some will be bathed in bed. Yes. So, as I said, bathing is assessment. You look for the skin. On the skin, if you are bathing a patient on the skin, you look for redness, pressure injuries, bruising, tears, rashes, and the likes. Moisture associated damages. So you also assess, whilst bathing a patient, you assess for mobility. Are they able to turn for you to bath their back or anywhere? The ability to lift their extremities, the ability to move their joint, flexion and extension. Okay. Any weakness in any part of the body as you are commanding them, any pain with movement. So we've done skin, we've done the mobility aspect. Okay, let's look at the neurological assessment when you are bathing a patient. When you were bathing them, were they confused? Okay, asymmetrical movement. Asymmetrical. If I bath your face, if I touch your face, your facial muscle, your facial nerves, if I touch it, this facial nerve should what? Should stimulate and squeeze. I'm looking at your face, the right and the left side, are they moving at the same time? Are they squeezing or there was a drop in one? It will help me to know stroke. Are they having tremors? Is there any weakness or coordination problems? So these are the things you should know. Then psychosocial status, their mood when you were bathing them, were they embarrassed? Were they withdrawn, anxious, and willingness to participate? Yes, a male staff is going to bath a female staff, a teenager, of course, who are more particular about what their identity. Okay, they are not comfortable. You watch their expression, they are not comfortable. You still say you want to bath them. Okay, you are going to cause embarrassment, and you are going to have issues with what their willingness to what participate. So when assessment opportunity is hidden inside the task, you should always what it says so when Nclex gives you a routine hygiene scenario, In the question, when you see that there is a routine scenario, ask what assessment opportunity is hidden inside this task. Okay, yes. So bathing sequence, I mean, when you get a slide and you go through, privacy and dignity are what clinical responsibilities. It is patients' privacy and their dignity are your responsibility as a nurse. Okay, so you make sure you close your doors, you draw the curtains, the window curtains, draw them down, cover the patient appropriately, explain what to do, explain what you are doing. Explanation is very important. Obtain consent and cooperation. Expose only necessary areas. Yes. So especially their perineal care, catheter care, ostomy care, bathing, toileting, and changing clothes. Getting the task done quickly does not override privacy and dignity unless an immediate emergency requires intervention. You don't rush through the procedure. Okay. We have areas like perineal care. You are taking care of somebody's perineum. Example, urinary or what? Fecal, patients with fecal incontinence. Privacy is important. You are taking care of indwelling catheters. Privacy. Someone has a diarrhea. Take care of their bump, their pad, their brief, whatever. Okay. Inspect their buttocks, their anus. Is there redness, skin break, all those one. Your creams to apply, skin integrity. Okay. Immobility, post-operative limitations. So the general principle for a female perineal hygiene is always when you are taking care of a female, you clean them from the front to their back. Okay. Yes, so you can get a question like this. This reduces the transfer of organisms from the anal region towards their urethra because UTI is very, women have a short urethra, unlike men. Yes. So the least thing, infection is inside their bladder. So be careful you don't infect the urethra. How about men? When you are treating a man who has what, who is uncircumcised, you first retract the foreskin. You do your care, okay, clean it nicely. Then you pull it back to cover the external or urethral meatus. Okay, so the intestinal tract contains organisms that can contribute to urinary infection if transferred towards the urinary tract for the females. Okay, so do not repeatedly wipe back and forth using the same contaminated tissue or surface or wipe. So you clean one, you throw it away. Take another wipe, clean, you throw it away. Take another one, clean. You take, yes. Okay. Somebody has incontinence. Somebody has incontinence of urine and bowel and bowels. So this patient with urinary or fecal incontinence is not what merely experiencing an elimination problem. They don't have elimination problem. Okay, they are not merely experiencing that. But your prolonged exposure to what moisture and irritants can cause what skin macerations, skin irritations, inconsistent incontinence associated dermatitis, skin breakdown, and all these type of infections. Therefore, when taking care of this patient, prompt cleaning is very important. Gentle drying is very important. Moisture management is very important. Barrier products when indicated, scheduled toileting, then frequent skin assessment, very important. So moisture associated skin damage is not automatically a pressure injury. Nclex pressure injury is not the same, plus or minus shear. They can also give you for issues of incontinence associated dermatitis. You will see that what in the question you see patient is having moisture and chemical irritations. Okay, let's go to the mouth. Oral care is very important than most people think. Yes, these are the benefits. The patient will be comfortable, the oral integrity, the appetite, the taste, communication, and all those stuffs. Somebody is taking care of a care home patient. In the night, the patient is going to sleep. They will take the patient's what dentures and keep it nicely, clean it nicely. How about the oral cavity of the patient? You clean somebody's dentures, you don't clean the person's mouth, the tissue, the mucosa, the integrity. Okay, people who have their teeth, they take care of their teeth. How about the teeth is standing on a mucosa, a bed? Okay, the tongue, the upper roof, and the bed of the mouth. Okay, so you do your lips assessment for what? Breaks and dehydration and all those stuffs. Your tongue, your teeth, your gum, all these structures inside your mouth. Okay, you assess it. How about oral care in an unconscious patient? This is where Nclex will worry you because they are more interested in it. Yes. So there is a major concern when you are taking care of an unconscious patient's oral care, especially those who work in ICU. Okay. In the morning, 6 o'clock, they said before 6 o'clock, oral care. Now, aspiration is a concern. An unconscious patient cannot reliably protect the airway. They can't. If they could, there wouldn't be an hot ET tube inside their mouth in the ICU. Therefore, positioning and secretion management are what the most important thing. You should take it critically. You can't just go and do oral care for them without positioning and managing their secretions. So, when appropriately, it is generally performed with patient position to facilitate or drainage. Most commonly, the side lining with the head turned laterally while using what? Suction as needed. Okay, because if the fluid accumulates, a lot of fluid accumulates, there's going to be what? An impairment, and there's going to be an aspiration. Never pour water or large quantities of fluid into the mouth of an unconscious patient because the mouth needs cleaning. Never do that. Okay, some people will use yanka and spaghetti suction stuffs to take all those stuffs. Okay, always think that airways come before and hygiene is second. In an unconscious patient, their airway is very, very important. Okay, I've already talked about denture care. You have to remove it carefully. Make sure you don't break anybody's dentures. You clean it appropriately. You protect it from break. You store them safely. And sometimes you label them. After that, you take care of the patient's oral hygiene, even when the patient has natural teeth. Okay. Removing dentures does not eliminate the need for oral care. So the gums, the teeth, oral mucosa still require what? Assessment and cleaning. Now let's go to the senses, the eye. Routine eye care. Yes, there are some people you use wipes to clean their eyes and those things because they are always tearing. Okay, and there will be all these clusters and all this all over their face. You clean them nicely. Their glasses, You make sure that you can see through. Okay, they can see well. There is no blurred lenses and all those stuff. So you do those care. When one eye is infected, avoid cross contamination, contaminating the unaffected eye. Okay. Yes. So you start the care from the unaffected eye. Let's say somebody has what? This thing, Apollo. What's the name of the Apollo? Yes. People have a lot of eye problems. Okay. Somebody has infection on the right eye, the left eye. The right eye is perfect. When you are going to do eye care, start from the right eye before you end on the left eye. Don't start from here before you come, because you can't finish and go and remove your gloves. It's the same glove. So don't touch the infection and bring it here. Okay. It is not about memorizing it, it's about what? Understanding the concept. Okay. Hearing aids. Okay. Hearing aids helps us to communicate. It helps us with orientation, safety, mobility, balancing, and patient participation. So if your patient uses hearing aid, okay, it magnifies the sound to their ears. Inside the ear, there is some there is some water, aqueous fluid. Okay, that will help you with what? Balancing and hearing, the cochlea and the vestibular. Okay, yes. So, and the eardrum and all those stuffs will help to magnify the sound. There are some people, they live in a very loud community. That sound, high pitched sound, has destroyed what? Their ear drum. That now, even when you talk very soft, they can't hear. So they need a device that will magnify the sound when you talk. If this patient's hearing aid is not, they are not wearing it, they won't hear what you are saying. They can't participate. So you should make sure the hearing aid they are using is okay. It is available for them to use it, and the batteries inside. It is the hospital's duty to buy batteries for them. Okay. Otherwise, your patient will not cooperate. They will be withdrawn, disoriented, and confused. Okay. Yes. So before concluding that an older patient is confused, first consider whether they can hear what you are saying and see you adequately. Okay. Let's look at taking care of or patient, dressing them. A patient with unilateral weakness. Okay. This is highly testable. That is why I highlighted it. Okay. Suppose a patient has right-sided weakness following a stroke. When you are dressing the patient, you are putting on the dress. Always start from what? Their weak side. But when you are taking away the clothes, you removed from what? The unaffected side. Okay. So you dress the affected side first, or the weakness side first. But when you are undressing them, you remove the clothing from the unaffected strong side. That's it. Why? Because it reduces unnecessary manipulation of the weak extremity and make dressing easier. Okay. Never pull on a weak arm, especially a hemiplegic patient or a severely weak upper extremity patient can be vulnerable to shoulder injury. You destroy their nerve plexus, okay, including what? Subluxation, causing so much complications to them. So don't pull. In care home, we call something drag lifting. Drag lifting. Okay. Drag lifting. You go and hold somebody's hand, then you pull them for them to stand. It is drag lifting. They will jail you. Yes, conjunctivitis. Yes, they will jail you. So we don't do drag lifting. You destroy the nerve plexus. Okay. So do not pull on the affected arm. Do not lift the patient under the arms. You see those guys, we are strong. One arm here, one guy will be standing here. You destroy the patient's arm. Allow the weak arm to hang unsupported for prolonged periods. Do not do that. Okay. You help them, stroke patient. So your palm will be in their palm like this. Then you are walking nicely. Okay. Yes. That is it. We don't use our fingers to turn a patient here, this side of the finger. We don't use it to turn a patient. Use your palm. If you use your fingers, you will cause redness and bruises. They can arrest you. Eh? These forensic guys, they will come and use their handkerchief to clean that part, and they will test everybody at workplace, and they will know that it is your fingers. So use your palm, okay, so that you don't create any marks on any patient. You use your palm inside the palm like this to turn a patient like this, okay. Don't use your hand, especially people who they are vulnerable to skin breaks. Toileting and dignity can be an major issue too. So patients may attempt to get up alone because then they have rang the bell, nobody is coming because they are embarrassed. They cannot wait. The urine is coming, the poo is dropping down. Okay. Yes. They do not want to bother staff. No, we have some patients, they don't want to worry people. Okay. Some of them are confused adults who are having UTI. They urgently need to urinate or defecate. Because of these factors, and they don't have what? Time. They don't have the patience to wait for you to come. And it will put them at a higher risk, a substantial risk of falls. So what strategies are you going to use? Depending on the type of patient you are taking care of, these are the strategies NCSBN has listed. Okay. Scheduled toileting. Call bell within their reach. It won't work for every patient, but it is a strategy they have listed. Their pathway, yes, sometimes you'll be busy, but make sure that from their bed to the toilet or to the bathroom, that pathway is clear. Nothing will cause them to fall. The floor is dry, not slippery. The patient is wearing non-slip what? Socks. You see that socks with different white stuff the hospital has been giving to patients. Don't let patients wear their socks they brought from home. Okay. Appropriate footwear, adequate lighting, assistive devices available and closer to their bed, walker, cane, and those stuffs. Prompt response to toileting needs. Where are the healthcare assistants? They'll be fighting with the nurses because they think the nurse should respond to the call lights always. Okay. Yes. So toileting can prevent falls. Suppose a confused adult repeatedly tries to climb out of bed. So, an approach that Nclex doesn't want you to do is that, yeah, this patient is confused. Old guy, care home patient, they've brought to the hospital, confused, UTI, trying to climb. Then you go and apply restraint. Okay. They are saying the better approach to go is to determine why the patient is getting up. You should know why they are getting up. Some of the possible answers you can get is that they need a toilet, they are in pain, they are hunger, distress, test, discomfort, confused, unfamiliar surroundings. So addressing the underlying need may, not shallow, may reduce what? The unsafe behavior. So try. Okay, de-escalate. Okay, comfort is more than pain medication. So comfort measures, including both pharmacological and non-pharmacological approaches. Can we reposition you? There are some nurses. Then the patient will call. Okay, they will go. Can I help? How can I help? Then patient will say, my side is paining me. Okay. Meanwhile, the patient is lying on that side. They will say, you have got paracetamol PRN. Can I give you some? Yes. Okay. You are giving medication. Meanwhile, the patient's muscles are stressed. Can we reposition? Can we do some relaxation therapies? Can we massage when appropriate? Can we give heat and cold applications? Can we distract on the televisions to take your mind sometimes from it? Okay, quiet environment, reducing unnecessary interruptions, sleep supporting, oral hygiene, cleaning and drying the bed, the bedding, making sure that it's clean and dry, no creases and cramps. Okay, can we move to the toilet? So depending on the patient, you get all these issues. Okay, there's a trap. A patient saying I'm uncomfortable does not automatically mean give analgesics. You need to do your assessment and do your interventions. So pain, on this note, we are entering into pain. In pain, when you are assessing for pain, look at the PQRST for ECG. That's the pain assessment. People don't know. Okay. The provocation, what is provoking? What is starting the palliation? Yes, patient is having the pain. They should describe the quality of the pain. Is it aching? Is it discomfort? Is it numb? Is it dull? Is it like so many pain qualities? They should be able to describe it if they can talk. The region of the pain, that's the R. We have two R's. The region, the location of the pain, and is it radiating? Yes. So somebody with a chest pain radiating to the shoulder, okay, or the neck should tell you where the pain is coming from. The severity of the pain, they should be able to tell. So on the scale of 0 to 10, where 0 means no pain, 5 means moderate, 10 means very severe pain, where do you place your pain? Then the patient will say, I am 4. Okay, you mark it, you know what to do. Sometimes too, you tell them the faces, okay, the faces on the wall, or you show them the pictures. Oh, you see that there's one face that is smiling. There's one face that is frowning. There's one face that is crying. There's one face, different faces they will choose, especially kids. They will choose. Okay. Yes. Then unconscious patient, the facial, the flag scoring. You get to all those things. Okay. But remember, if the situation is immediately dangerous, stabilization takes priority over elaborating, doing all these PKRST assessments. Okay. Yes. So the pain scale. A patient A reports that they have what? A pain of 9/10. Another patient B also reports that they have a pain of 5/10 with new chest pressure, diaphoresis, and dyspnea. Who has priority? So Nclex will say that, okay, both of them have pain, but this guy is having a new onset of chest pressure and is diaphoretic and dyspnea. Okay, he's having what cardiovascular issues on top of that. So let's prioritize the B. Why? Because priority is not determined simply by the highest pain score. It depends, or say the second patient's manifestation could literally indicate a life-threatening cardiovascular problem. So severity score does not replace clinical judgment. Okay. So some of the non-pharmacological pain management you can do, not always to jump to give paracetamol when you can do things to help. So all these non-pharmacological scoring are here. Okay. Yes. Do not assume that non-pharmacological intervention is equal to pain medication. No. If it doesn't work, if you give music and there is still pain, give meds. If you distract them and there is still pain, if they do breathing exercise and there is still pain, give. Okay. Now let's go to heat and cold therapy. Yes, I've listed. If you want to go deep, we are going to waste a lot of time. So I've listed it point because these are the areas we are getting. It goes with the curriculum. So if you learn it, you can close your mind, close your. Don't even learn anything again. You pass Nclex. Yes, because I'm teaching you straight from the curriculum. Okay, so heat and cold therapy both can provide comfort, but they have different physiological meanings. When do we apply heat? Remember, when you apply heat, you are going to dilate the blood vessels. So if I dilate, if this is my skin, this is the skin, and we have blood vessels under it, like this, and I apply heat here, okay, the blood vessels will become bigger, like this. You are going to dilate it. That means that there is going to be more blood supply, okay, to this area. But the same skin, if I apply cold, see, to this area, it is going to constrict the blood vessels, small like this. So there's going to be what? Cold, and there's going to be what? Vasoconstriction and reduced blood supply. So this is the physiology of what? Cold and heat therapy. Okay. You are managing a patient that you don't want the patient to lose a lot of blood. You don't want the patient to lose a lot of blood in that area. You want to reduce blood flow to the area. Okay. You apply cold. Yes, both of them give comfort, but we don't apply them at the same time. That is what I mean. Okay. Yes. So generally, these compresses and all those things, they cause either vasodilation or constriction, increased blood flow or reduction. Muscles will relax and decrease stiffness. Okay. So cold compress will cause the opposite side, reduce swelling. Okay. Somebody hit you, blow, boom, on the head, or a patient knocked the head when he was going to the bathroom, and hit the head on the wall. There is a swelling on the head like this. Because there is a swelling, we don't want this swelling to become greater. Okay, so we don't want what? More blood supply to come here and cause the tissues here to swell more. So we apply cold compress, reduce blood supply, and the tissues will shrink. The muscles will be relaxed, constrict. Okay, yes, so that is what we mean. But there comes a time that both heat and cold compress will cause what? Risk, will bring risk. Though it's a therapy, but there is a time that we don't need it. In what patients can we see this as what? The contraindication. A patient with impaired sensation. If somebody has a skin here and you touch the skin, T for touch, and the patient cannot feel, you pinch them, they can't feel anything. Okay, you don't have to apply. People with cognition issues, cognition, interpretation of what? Nervous activities or activities around them, cognition, your ability to interpret. Okay, if I touch your skin, there are nerves here that should send, we call them afferent nerves. They should send information to the brain, and this brain will interpret it. That is the cognitive function. So when they interpret it, they will now what? Respond by what? Giving a response that, hey, this is fire, take out your hands. So the nerves that will bring the the information back to the skin is what we call the efferent, the effect and the affect. Okay, the effect and the affect, the A and the E's. Okay, so this nerve is intact. This nerve is intact. There's a problem with this guy, the brain. They cannot interpret. We have a cognitive impairment. This patient, don't go and give them heat and cold, because what if you put them in a bathtub, big bathtub with temperature, very hot, boiling water? The brain cannot interpret that there is burns going on the skin. So if you put this patient in that water or apply that heat, you will cause burns. People with circulation problems don't try, because the blood vessels cannot expand and constrict. Okay, don't try. People with communication, something is happening to them, but they cannot talk, they can't communicate. Don't apply. So these are what the curriculum is now saying. That, hey guys, shine your eyes. Okay, you've seen that a lot of people fail, not because they don't know. Okay, but there are some little understandings that people are missing it along the line. Okay, yes. So the patient may not recognize or report excessive temperature exposure. For example, a patient with a significant peripheral sensory loss may not realize that a heating device is causing tissue injury. So impaired sensation plus temperature therapy causes increase. Okay, let's look at sleep. A hospitalized patient often have a disrupted sleep because of noise, all this stuff, pain, anxiety, lighting, medication, and unfamiliar environment. Okay, so what should the nurse do to help them to sleep? The nurse, starting from him or herself, should cluster the care. Okay, always start from yourself before you advise people. Okay, so you should cluster your care, list your care, prepare your equipment, go to the patient's room, do your care. Okay, allow the patient to sleep. I was saying the other time that a lot of nurses don't cluster medications. In USA, if you say medication, you have the opportunity to give it 1 hour before, unless it is time sensitive. If it is not time sensitive, you have the opportunity to give it 1 hour before and after. So if you are supposed to give the medication at 4 p.m., you can give this medication 1 hour before 3 p.m. You have this window. Or you can delay and give this medication at what? 5 p.m. If only that medication is not time sensitive. Take note of if there is an if clause. So you had a patient who was due for paracetamol at 3 p.m. Para here, 3 p.m. At 4 p.m., they have folic acid to take. These medications, they don't interact. They have different pathways, you know. Then at 5 p.m., they have melatonin to take. Example, oh, you don't take melatonin at this time. Melatonin to take. These three medications don't interact. Okay. So since they all fall within this bracket, what I can do is this 3 p.m. medication, this 4 p.m. will be 1 hour after. So I can push this medication to 4 p.m. The para here. And this melatonin, that is 5 p.m., it falls under the 1 hour window before the administration time. So I can also push it here. So 3 p.m., I'm not entering into the patient's room. 4 p.m., I'll go and give all these three medications. And 5 p.m., I'm not entering the patient's room. I have clustered care. Okay. Decreasing noise. People will be talking on the corridors, making a lot of noise. Okay. If you're able to control lighting in the room, melatonin works with darkness. Okay. So you need melatonin and darkness to work. You can't give melatonin and patient's light will be on. It doesn't work like that. Managing pain and promoting comfortable positioning. Then assisting with what? Toileting before sleep. Yes, otherwise they will wake up in the night, bladder is full, bowels are full. Okay, yes. So cluster care, but there is a caution. Don't overdo it. A lot of people junk the care. Okay, and go and do. Okay. A severely ill patient may require rest between activities. Let's say the physiotherapy, they want to come because they have a lot of patients to look after. They will come and pounce all the session, everything. Patients should work with the worker at the same time. Patients should do this at the same time. They will be tired. Your goal, you can't reach your goal. Okay, so you give them some rest in between activities for them to recover energy. Let's go to delegation. We did delegation in management of nursing care, basic care and comfort. There is delegation here. Okay, basic care and comfort contain many tasks that may be delegated to assistive personnel when the patient is stable. Okay, who is the head of the shift? Is the RM. Who are the assistive personnel? LPN. Okay, they are assisting the nurse to look after the patient, and RNs. Okay, they are the assistive personnel. So the nurse should now ask, which of the patients are stable that I can give to these guys? Okay, so this one can take and this one can take. Does the hospital, that's the first question. Second, does the hospital allows me to give this time of care to the CNA, the NA to do? Example, when you go to the emergency room, we have what we call the emergency techs. Some hospitals allow the techs to set up IV lines. Some hospitals too don't allow them to set up IV lines. So yes, your RN, when you are learning your curriculum, it says that allow the assistive personnel to pass IV, but the hospital you are working in does not allow them. So when you go to Rome, you do what the Romans do. So these are the things. If patient is not stable, and if patient is not predictable, you can't predict because some of them they just change condition. ICU patients, okay, they will get arrhythmias within a short time. Don't delegate their care. Don't delegate their care. Okay, good. So we are looking at three things here: stability and productivity. The tax is within these people, their role, and the institution you are working in also allows that. Okay, cool. So that is it. In all, the RN retains the responsibility to for the nursing assessment, clinical judgment, evaluation, and decision making. Okay, good. So this is the rule. I've taken you through. Now let's go to feeding a patient. What are the safety concerns about feeding a patient? Hmm? Which patient, let's look at this scenario, which patient will be more appropriate for routine feeding assistance? Routine feeding assistance. The word is routine. Patient A, a stable patient with an uncomplicated arm fracture who needs help with eating because the dominant hand is immobilized. And patient B, a patient who recently had a stroke and coughs when drinking water. Which of these patients are you going to delegate? And which of these patients are you going to assist with feeding? The answer is what? A. Okay. He has what? Uh, because this patient B has what? A possible dysphagia. They cough when drinking water. We will get to stroke patients so you understand. And aspiration risk. The situation requires nurse to come and assess this patient before the CNA can feed the patient. Okay, so you have to do the dysphagia or the swallowing assessment. Yes, feeding is a basic care until swallowing becomes unsafe. You are a nurse, a CNA in the house. Your grandfather is having stroke because you work in a hospital. Everybody is saying that feed this patient for us. You went to your friend's house to visit them. Their uncle is having a stroke. Okay, because you work in the hospital, everybody in the house will say, "Oh, come and feed this patient, come and help us." This is it within your scope of practice or not? If something happens and the patient chokes, you are going to jail. Okay, so because there is an airway and safety problem over here. Okay, there are some questions you should ask yourself. You Now let's go to the bathing trap. Yes, everybody can bath anyone in this world, but there is a trap with bathing. Let's go and learn it. A stable patient requires assistance with bathing. Cool. This stable patient will be delegated. Okay. But suppose during the bath, the assistive personnel observes that the patient's sacrum is red and the redness isn't going. It is non-blanchable. Okay. When I pinch, when I pinch your skin like this, I depress it down and I release my hand. If you are fair, you see some red thing there. Or even when I pinch it and I release my hand, you see the red drawings there. Okay. That is called what? That redness. If I give you some few seconds, it will vanish. Yes, we call it what? Blanching. It means a good blood supply to that area. But if I pinch you and I leave and that redness is not going, we call it non-blanchable. Okay, this patient needs to be assessed by what the RN. So CNA went to do, okay, went to do care. You saw the patient's sacrum is red. Okay. and it is non-blanchable, the RN should assess why. Because the situation has moved from everyday bathing of this patient, it has moved from routine care to abnormal assessment finding. So, healthcare assistant, if you see anything, come and report. See, report and go and sit down. When we were, there are some people, they will come and tell you, they have told you, if you don't do anything about it, RN, they don't care. If anything comes, they will report you that they told you. Some of them will even write in their notes, in their patient file, that RN has been informed about this problem. Okay. So if you don't do anything about it, okay. So assistive personnel can observe and report. That is your job. Report. But we Africans, when they report us, we are always offended. Okay. Yes, that is another topic for another day. The RM must assess and make nursing judgments about that. Okay, good. Never delegate assessment. I'm not going through this because assessment, the art pie, assessment, diagnosis, planning, implementation, evaluation, never, it is the RN's job. You are not supposed to do that. Okay. Now let's look at some questions to ask yourself. Whenever you see delegation that you feel like, or your mind is telling you to delegate, ask yourself these questions. What should the nurse do first? Okay, good. Secondly, assessment is often correct, but not always, especially when you meet Nclex questions. The question is asking you, what should I do first? What should the nurse do first? Okay. What should the nurse do first? What should the nurse do first? We will see questions like that. What should the nurse do first? Yes, the API says assess first, but assessment is not always the right thing. Okay, it's not always correct. If the patient is in immediate danger, intervention comes before assessment. If a patient is having difficulty breathing, you have seen oxygen standing there, throw it on the patient before you come and check assessment for airway and breathing. Okay. A weak patient begins falling whilst being assisted to the bathroom. They are falling, in the process of falling down. What do the nurse do first? The questions will come. Assess blood pressure. Patient is on the way falling down. Assess, then they will write the assess blood pressure. Ask about dizziness. Protect the patient and lower them safely. Document the falling. This is documentation. This is an assessment, and this is implementation. Okay. Yes. So in this scenario, implementation will come first before assessment. We are not doing robotic nursing here. Okay. So ABC, let's connect basic care and comfort to ABC. ABC problem. Okay. So this is perhaps the most important lesson for today. So open your eyes. A basic care can suddenly become a priority emergency. Example, you are providing oral care and the patient develops choking and cyanosis. You are doing basic care. Suddenly, patient is choking and becomes cyanosed. Not only choking, on top of it, cyanosis. Forget the oral care. Okay. forget this intervention and go straight to the airway, because the airway becomes what? A priority. A, B, C, D, airway, breathing, and circulation. Okay, so we have some questions. I'll get them for you. Okay, you are assisting. As another example, you are assisting with ambulation, and the patient develops severe chest pain. Forget the ambulation goal. Doctor wants to discharge the patient. They've asked you to do a cardiac walk. Okay, they are walking on the corridors of the ER, and suddenly patients say, "My chest, my chest, my chest." You say, "Oh, madam, we are going to the door. We are walking to the door. Let's walk to the door and come back so that we know." No, you forget about the goal of ambulation. Then you assess and stabilize the acute problem. Another scenario, you are feeding a patient and the patient suddenly cannot talk or cough effective, airway blockade. Forget the nutrition, and airway takes priority. Okay, yes. So write this down. If you don't have pen and paper too, if you get the slide, then you 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 catch this point 36 in basic care and comfort. Activities of daily living. Activities of daily living, point 36, part 1, point 36. Write it down. When several basic care and comfort options look reasonable, especially your questions, those who are writing Nclex very soon, when you see basic care and comfort questions, and you are confused about how to pick your answers, think through this sequence. See, it is coming straight from the curriculum. I'm not drafting it for you. They said the first question you should ask yourself is this an immediate life threat? So anytime in medicine we say immediate life threat, we are looking at the ABCDEs. This problem that is going on, does this fall under these guys? So airway, breathing, circulation, that's your first question. Okay, so you look at your answers. Okay, this challenge that I'm having, which of them falls under ABC? Second question, these answers before me, which of them falls under safety? If I don't do something now, the safety of the patient is going to be impaired. Example, falls, aspiration, and injury. Okay, right. The third point you should ask yourself, is the patient acute or unstable? Then the next one is actual problems. Okay, often outrank what potential problems. You remember our Amasa? Hey. The next question you should ask yourself is what? The basic physiological needs. You see, for them, they have expanded it. The basic physiological needs, somebody needing nutrition and somebody needing oxygen. Oxygen will come before nutrition. Somebody is ringing the bell, wants to go to the bathroom. Okay, especially people who are about to die. Some of them will say that I want to go to the toilet, the bathroom. They will tell you. Meanwhile, if you look at them, they are unstable. They are dying. Their blood pressures and vital signs are crashing. Will you put them in a wheelchair that you are taking them to the bathroom? They will go and die there. That is what we are saying here. Psychosocial will be the last thing. Dignity. You need oxygen. You are complaining of chest pain. Okay, it's an emergency. Somebody has pressed the rapid response team. They are coming. Okay, You are talking about breast here, dignity. No, we need to do a quick EKG. It's 12 lead ECG. Put some of them will even cut your clothes. Okay, yes, it was an emergency. Okay, yes, so that is what you should know. Okay, so everything I have said in the activities of daily living, under basic care and comfort part one. Okay, these are the things you should know. Okay, a situation and what you are supposed to know. When you get a slide, go through. You are addressing a stroke patient. The weak side goes first. You are undressing a stroke patient. You remove the clothes. Okay, then the strong out side out first. Somebody is hemiplegia. You support them. Don't pull their arms. Don't put your hands under their armpit like this and lift them. Drag lifting. Somebody is having incontinence. Think about their skin and blanchable stuffs. Okay, stable. A patient is stable. You are going to do routine bath because they bath every morning. Okay. Yes, you can delegate. RN, you are busy serving medications. You can take this patient to so delegate. Somebody is feeding and coughing. It's a sign of dysphagia. Stop. Assess for aspirations. Okay. Patient begins falling. You don't catch them and make them stand. If you do that, it's against the law. Somebody is falling. You don't catch them and that you are preventing them from falling. No, you guide them to the floor so that they don't injure themselves and the impact will not be high. Okay, that is it. Somebody uses hearing aid glasses. You consider what? Sensory assessment. So these are the situations. Okay, Nclex situation, basic task. ABCD is you are doing care, giving care to a patient. Then you realize that any of these ABCD components are deteriorating. Okay, forget about what you are doing for the patient. Concentrate on the ABCD. If somebody is having impaired sensation, heat and cold, tissue injury. So when you get a slide, take your time, go through. This is basic care and comfort. Okay, part one today. Okay, now let's look at some clinical thinking questions. When answering a basic care and comfort question, mentally ask yourself, is the patient stable? The AMASA, remember, the AMASA, it helps you to prioritize. So the ABCDs, the Maslow, the acute over the chronic. This is my personal invention. It is not in any book. Okay. The stable over unstable and the actual problems over potential problems. Okay. Yes, this is how we do prioritization. If you are stuck with your answers, compare with this. Okay. Yes, we have those of you who joined class that day, you know how to use a master, and prioritization will not be a problem for you again. Okay. Yes. So the second question, is there an airway or breathing circulation problem? Is there an immediate safety threat? Okay. The next question, can this task you want to do for the patient, can they do it independently? You want to brush somebody's teeth, meanwhile they can brush their own teeth. If you force it, you are taking away independence. Okay. Can this task be delegated? Is the patient stable? Are they predictable? Or you can't predict them? Yes. Somebody, is their care routine? Are they doing what? Nursing judgment or no nursing judgment required? Okay, there's question 6. Did something abnormal occur when you are taking care of the patient? Yes or no? If yes, stop it as a healthcare assistant, LPN. Call the nurse to come and assess. Okay, yes. So these are the things you are supposed to do. Okay. Then the mini Nclex challenge questions or situation. Don't look for memorized rule. Apply the framework, and that's it. Your amasa, apply it. A nurse is caring for 4 patients. Which patient should be assessed first? We know C. The patient who had a stroke yesterday and begins coughing repeatedly while being fed with what? Breakfast. Okay. Yes, because the coughing is a sign of what possible dysphagia or aspiration, and it's an airway safety problem. Okay. Yes. Then the rule for basic care and comfort: safety, independence, clean, and comfortable. But always remember that safety comes first. Okay. Then to end part one, you should leave this lecture knowing that basic care and comfort is not a simple nursing care. When you want to learn Nclex, I told you Nclex is a lifestyle. It is not a book that you are reading. It's a lifestyle. Okay. So Nclex uses basic tasks as a vehicle to test your clinical judgment. If you are somebody who can judge well, and when you come to work to your colleagues too will test your clinical judgment. Sometimes they will bring some patients to you, okay, to test whether you are good with clinical judgment. So the fact that the nurse told you as an RN or whatever, or your manager told you that hey, Ayariga, go and bath this patient, does not mean you should carry and go and bath. No. You should tell your manager that no, this patient is high for risk. So I can't take him to the bathroom alone. I need somebody to help me. Okay? Feeding. Yes, the patient has not been assessed by what? The nutritionist or by the doctor for feeding. Okay? You can't go and feed the patient. So it's not every patient that comes to the emergency room that will say, I want to eat. Then quickly the nurse will go and carry some donut and stuff and give it to the patient to eat. You are going to cause problems. Patient has come to the ER with severe abdominal pain, vomiting, and diarrhea. This patient in the next moment is requesting for drink, requesting for this, requesting for ice. Safety problem, clinical judgment. Okay. Don't let your patient change condition from a stable patient to a rapid response patient. Otherwise, people will say that you don't get clinically. Okay. And no nurse comes to work and look after only one patient and go home in 12 hours. Definitely, they will give you 6, 7, 5, 4, 3, 2, 1 patients to take care of them at the same time. All of them are calling you for their needs. You have to sit down and prioritize. Okay, prioritize. That is why it is very important to learn acuity. One day I'll teach you acuity. Okay, good. Toileting patient can become a fall prevention question. Okay. Incontinence care can become a skin integrity question. Heat therapy can turn into a burn and injury situation. You thought you were doing good, you have caused a problem. A delegation situation can become an RN assessment question. And pain can change into what? ABC and cause arrhythmias. Okay. So these are the things you should know. Okay. Right. Now let's go to part two. So I've got some questions for you. Let's do part one. Part one questions. Five questions. Okay. Part one question. We are not in a rush. So part one question. Sharp. The nurse receives morning report on four patients. Which patient should the nurse assess first? Sharp. Send your answers. Question number one. Send your answers. Yes. The nurse receives morning report on four patients. Everybody should answer. This is to test whether you understand, not a rush. We are not here to finish the slide and you go home that you're happy. When we give you situation, you don't know what to do. Good. Yes. So the patient with sudden patient who becomes suddenly confused. Confusion is about the brain during a bed bath. Okay. A patient with rheumatoid arthritis requesting assistance with, okay. A patient with left-sided weakness who needs assistance to the bedroom, and a patient with urinary incontinence requesting perineal care. Yes, so the answer is C. Let's go to question number two. If it is too small for you, let me know. Question number two. Question number two. Yeah, shoot your answers. Let me know if you understood what I just taught you. A patient recovering from an ischemic stroke has right-sided weakness. The patient can wash the face, the chest, and the left arm independently, but needs assistance with the remaining areas. Which nursing intervention is most appropriate? Most. This is a comparative superlative question. I've taught you people, so you know. The most. Question number two. Yeah, so you write your question number and the answer, please, so that I know. I know which one you are answering. Yes. Question number two. A stroke patient with right-sided weakness. Yes. Wow. Mrs. Everest, are you asking me a question? Or you are answering a question? Because you said, what is 2C? I don't understand. Yes, more answers. We are more. I need more answers. More answers. Yes. So the intervention that is most appropriate. Okay. Question number A is complete the entire bath to conserve the patient's energy. Okay. Encourage the patient to perform the portions of bathing that he can complete safely. Okay. Ask assistive personnel to perform the task entirely. So using the Amasa Patient recovering from ischemic stroke, recovering, ing. He has not recovered. So patient is still not stable. So this one is out. Delay bathing until the patient regains full function. No, you can't deny them of basic care. So C and D is out. Complete the entire bathing to conserve the patient's energy. Okay, you are doing 100% for them. You are taking away independence. So question 2 is B. Okay, you do care with the patient, not for the patient. You always do care with. Always remember this statement: with the patient, not for the patient. So this is right. So everything you do for anybody, do with them. If you go to somebody to help you and you are helping them, do give them the help. Do it with them. Don't do for them. If you do for them, they become lazy. They will expect you to always do for them. Okay. And you are taking away independence. So that is what, the rationale is what I'm giving you, that you do care with the patient. You are promoting independence in the patients. Okay. Do you understand? Now let's do question number 3. Question number 3. Yeah, shoot your answers. The nurse is teaching a patient with right-sided weakness how to dress independently. Right-sided weakness, how to dress independently. You are teaching them patient education. So which answer are you choosing? You write the question number, then your answer beside. Shoot. So you see, you learn, and then I will give you a safety question. Yes. To shoot your answers. Question number 3. Shoot your answers. Shoot your answers. Which action by the patient requires further teaching? Further teaching. Question number 3. Shoot your answers. Good. So, which action by the patient requires further teaching? So, it means the patient has done something that it wasn't right. So, the nurse must intervene to teach the patient that no, 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 no. You should have done it this way because this and this and that. Okay. So, the nurse was teaching the patient with right-sided weakness. Where is my pencil? This is the patient. This is the right side of the patient. This is the left side. Okay. So right and the left. So he has a weakness at this side. Okay. To dress independently. Which action by the patient requires further teaching? Further teaching. The question has highlighted this. Okay. Placing the right arm into the shirt first. B. Removing clothing from the stronger arm first. C. Sitting while dressing to reduce falls risk. D. placing the stronger arm into the shirt first and then attempting to pull the weaker arm through it. Okay, so the answer is what? D. The answer is D. Okay, so we said that the you dress the weak side first. Okay, when you are dressing them, but when you are undressing them, you remove the strong side first. So the question says that the nurse is teaching them how to dress, how to put on the dress. Okay, how to put on the dress. So when you are putting on the dress, eh, the weak side, that is the right side, the right arm should go first. But when you are undressing them, when you are removing the clothes like this, taking it off, the strong arm should come out first before the weak side. So if you look at the D, placing, he was dressing. So he rather dressed the strong side first. Sorry, the weak side first. Okay. And then attempting to pull the weaker arm through it. No, you are causing what? More manipulations of the right side. So the nurse should intervene and help with the situation. Okay, question number 4. Question number 4 for part 1, ADLs. During a bed bath, which findings should assistive personnel report to the RN? Select all that apply. SATA question. Shine your eyes. Shoot. Yes. Yes. So you write your question number and the answers to it. Question number 4. Write your question number. Then you write your answers to it. During a bed bath, which findings should the assistive personnel report? Who is assisting the nurse? Is it the UAP, unlicensed assistive personnel, or the licensed practical nurse? Which one? Okay, yes. So shoot and let's go. This is SATA question. Yes. Yes. Okay. So let's answer it. Good. Let's answer. So during ING, so the birth bath is still ongoing. Which findings should the UAP report to the RN? Okay. So let order apply. Remember, it is good for the UAP to always report when there are findings, there are concerns. Okay. So A says a new non-blanchable. They have changed English for you. Redness over the sacrum. Cool. Okay. So this is part B. The patient washes the face independently. This is a sign of what? Independence. So why should I go and report? Okay. C. New swelling on the left calf. New swelling on the left calf. Yes. It wasn't there before, but I am now seeing it. So the nurse must know and the nurse should assess. Okay. So C is part. D. The patient requests deodorant. This is a patient request. It is not a physiological problem. Okay. So it's out. E. New confusion. New confusion. This is a central nervous system concern. Okay. So yes, we will pick it. Hey, they are jumping the answers. Then F. A new skin tear on the elbow. This is a cheap question. A cheap question. I did not read the questions. Next time I would have made it so tight so that you cry like yesterday's one. Okay, so ASEF, ACEF. If you got all right, 4 over 4. If you got one wrong, take one from your marks. Okay. Sister Judy is laughing at me. Next time I'll make it tight for you. Okay. Number 5. The nurse observes the assistive personnel providing perennial care to an uncircumcised male patient. Which action requires intervention? I spoke about uncircumcised patients and how to deal with their penis when you are taking care of it, especially they are wearing catheter. Okay. So which action requires intervention? Number 5. More answers. Yes. Mary Sapon. You are laughing at us. You are laughing at the men. Mary Sapon. You are taking care of our uncircumcised penis. What should you do? They said wherever you took it from, when you finish, take it back there. Is that not the world's philosophy? Yes. Wow. Prince Zuka, I love your answer. Prince Zuka. Yes. So this one it's retracting the foreskin gently. Yes, that's a nice point. Okay. Clean beneath the foreskin is very important. Make sure it's dry after cleaning. Then after everything, you move it back. The foreskin, you retracted it. So make sure you pull it back to cover the urethral meatus and all the penis, the tip of the penis. Okay. So this healthcare assistant left the foreskin and went away. You cause infection. You cause conditions such as paraphimosis. Okay. Yes, of the penis. Yes. So that is it. Question number 6. The patient with severe fatigue. Let me see if I can make this. Oh, no. Okay. A patient with severe fatigue secondary to heart failure needs morning hygiene. Which approach best demonstrates appropriate nursing care? Question 6. Should you write your question and the answer beside? A patient with severe fatigue, secondary to, in Ghana, they will say second degree to heart failure. Secondary to heart failure means what? Morning hygiene. Okay. So he got the fatigue from the heart failure. That is the interpretation. Which approach is best to demonstrate appropriate nursing care? Yes, he too deserve a care. So shoot your answers. Yes. Let me check your answer. Wow, 9 points. 9 points. Yes, I regard the previous machine must be kept secret and private. Yes. So severe fatigue. A heart failure patient with severe fatigue. Then it means that heart failure is a severe condition. Okay. Severe fatigue. Okay. Yes, I like your answers. Thomas is laughing at me. Okay, let's look at the answers. Which nursing a patient with severe fatigue secondary to heart failure needs morning hygiene? Okay. Which approach best demonstrate appropriate nursing care? One, insist. This is by force. So this, if I was answering this question, this one is out. We don't impose care on people. Insist on a complete shower before breakfast. Provide a partial bath with rest periods. Oh, wow. And allow the patient to participate as tolerated. Okay. C, eliminate hygiene until the heart failure resolves. When is it going to resolve? Perform all hygiene needs, allowing the patient to participate. So the B stands out. Yes. So people with heart failure, the least thing they get tired. Ventricular, left ventricular and right ventricular failure. Okay, the least thing you are tired. And the question even gave us the answer that the patient is having severe fatigue. It means that the heart failure is severe. So this patient, when you are taking care of them, energy, the word energy is a big factor in their care. When you are helping them, make sure you don't waste their energy. Otherwise, they will be tired. They can even collapse and pass out. Okay. So you want to bath them, morning care, whatever. Partial bath is perfect. Okay. Then you allow them to participate at their own pace. Perfect. Then you do that with rest periods. They bath their hands more. Are you tired? Yes. Okay. Take your time. I'm with you. Take your time. Let them rest. Then, can you bath your legs? Yes. Okay. Bend down and bath your legs. They bend down. They bath. Okay. Sit in there. Sit on the wheelchair or the bathtub. Okay. Are you okay? Yes. So with rest in between periods. Okay. So those who chose B, you are right. Perfect. Okay. Right. Okay. Question number 7. Which tax is most appropriate for the RN to delegate to a trained assistive personnel? We call them the licensed or the licensed assistive personnel. Yes, or the certified nurse assistant, the CNAs. They have been trained and certified. Yes, question 7. Shoot. Delegation. You know the rules of delegation now. We have 30 minutes more for our 3 hours to be over. Okay. We are taking it one by one so that you catch the concept, not to rush. Okay. So 7 says the answer is C. Everybody chose C, so we don't have to go through, meaning you understand the question. 8. A dependent unconscious patient requires oral care. Which nursing intervention is most important? Yeah, shoot. A dependent unconscious patient. Okay, the question has already shown the answer. Shoot. I've not even read the answer, but I know the answer I will choose. And Nclex is about grammar. Let me see. Which nursing intervention is most important? Okay. Yeah. Okay, so question 8, I'm getting double answers. So it means I'm getting triple answers. So it means people don't understand the question. Okay. Okay. Right. So question 8 is saying that a dependent. So if they say a dependent, it means that 100% they rely on somebody to help them. Secondly, they are unconscious. Okay. So that even explain why they are dependent. But it's requiring what? He requires oral care. Okay. Unconscious patients never put water in their mouth that you want to rinse. No. So which nursing intervention is most important? A is out. If you choose A, out. Use generous amount of water. Okay. Don't let them confuse you and trick you. This is a trap. This answer is a trap. By using this word generous, it's a trap. Don't let them push you to choose this answer. A is out. Position the patient, yes, unconscious, to reduce aspiration risk, okay, and have a suction available as indicated. This is a safety intervention. So you are preparing yourself, safety preparedness. Place the patient comfortably supine. No, they are supposed to be on the lateral position, unconscious patients. Leave loose dentures in place throughout the procedure. You can remove it accidentally and they will swallow or it will choke them. So the answer is B. Those of you who chose B, thank you. Okay, thank you. I know it will confuse people a little. So you see, basic care and comfort, you might think it is easy, but they can frame the question and you'll be confused. Okay, that's why you need the physiology. Yes, we will do the questions, but come and listen to the physiology to make life simple for you. Question number 9. During morning care, which finding requires the most immediate nursing intervention? Okay. During morning care, which findings require the most immediate nursing intervention? Charlie Thomas, today I'm coming to beach you. So after class, I'm going to beach. I'll meet. We have to meet at Ontario Beach. During morning care, I love the way it is the sun is shining today. During morning care, which finding requires the most immediate nursing intervention? I love the answers. Question number 9. Let me see if I have any different answer. Okay. Question number 9. Okay, so it means clearly everybody understands what is going on. So, yes, new cyanosis of the lips. It is a central cyanosis. Okay. Number 10, a patient who normally performs all ADLs independently suddenly requires assistance eating, dressing, and toileting. Which action should the nurse take first? Which action should the nurse take first? A patient, he used to do everything by himself. Now, suddenly, he can't eat, he can't dress, he can't toilet. Which action should the nurse take first? 10. Please don't copy anybody's answer. Yes. Don't copy anybody. Understand the question. Do yourself that me, I've written my Nclex. I don't need any Nclex again. It is you that you need to. So if you copy somebody's answer, you don't get it wrong and get the explanation. That is it. When you meet the question alone in the exams room, nobody will be there to explain it to you. So be honest with your answers. Be honest to your own self. Wow. So, yes, assess for the cause of a sudden. This is a grammar question. Functional decline. Okay. So, guys, we have 20 minutes left. Okay. So I can take you to the beginning of positioning and body alignment, body positioning. Okay. We can do positioning. Then I don't want us to cross above 3 hours. So that's we mean not a rush. Okay, not a rush. We will finish this slide, get to another slide, finish it. Then we are done with basic care and comfort. I'm with you throughout the weekend. So make a time. Okay. Yes. So part 2 of basic care and comfort. We have done with activities of daily living in part 1. Part 2 is talking about what? Body positioning, alignment, position related safety. So the focus of part 2 is that the nurse should understand why a position is used, not simply memorizing names. Okay, why should I need to position this patient? A patient is going to do a laminectomy at the back. Okay, we are going to feed an unconscious patient. The doctor has come to the ward to do thoracentesis. Okay, why should I position this patient this way and not that way? Okay, a child has come with asthma. Why should we position the patient in this way, not that way? Understanding the physiology is the most important aspect of life. You went to church, somebody is what having chest pain. Which position are you going to put this patient? Yes. So why is position so important in nursing? Okay. The positioning questions are rarely just what position is this? But Nclex is more likely to give you a clinical condition and ask which position is safest. So position can affect your airway patency. It can affect your breathing in and out, that is ventilation and oxygenation. It can affect your aspiration. It can affect you to aspirate. It can affect your venous return, especially people with intracranial pressure. It can affect your intracranial pressure itself and let the pressure go high. It can affect your tissue perfusion. It can affect your injuries, pressure injuries. It can affect post-operative complications. It can affect drainage of tubes. Okay. It can affect the comfort of the patient and it can also affect musculoskeletal alignment, especially people with cervical, okay, the neck injuries and all those types, okay, spine injury. Yes. So, what the key question we should be asking ourselves is what physiological problem am I trying to correct or prevent by changing this patient's position? Which body system are you trying to protect? Or are you trying to prevent from damage? That and because of that, I need to position the patient this way. So these are the, let me bring it down a little. So the major patient positions, their descriptions and the common Nclex association. Why do we put a patient at the supine position? We want them to lie on their back flat because we want to do a general assessment head to toe. And we also want them to rest. But when you travel abroad, you realize that you see a patient will come and tell you that I sleep on my right, I sleep on my left. Those people, we call them side sleepers. So when you go to the supermarket to buy pillow, we have pillows that have been created for people who sleep on their side and created for people who sleep on their back. Okay. Then we have the prone positioning. Why do we put a patient on the prone position? That is lying on their abdomen. Maybe you want to do a surgery of the back, or we want what there are some selected respiratory conditions, okay, or we want to redistribute pressure in the system, okay. Lateral positioning, that is the side line. Yes, aspiration prevention, especially you tilt the head to the left. And pressure redistribution also comes in. The Sims position. The Sims position is just like the prone. Okay, they lie on their abdomen, but a little bit tilted to their side. That is the Sims position. We use it for sometimes rectal examination and placement of enema. Okay, the semi-fowler's position, we grade it. So when we say the fowler's positions, they are brothers, we grade. So 45, 30, and 45. Okay. Then, so if you take, this is the angle on a straight line is 180. So the guy in the supine position is assuming 180 degrees. Let's create a perpendicular line across this horizontal line. We get what? An angle of 90 degrees at the junction of meeting. Divide this 90 degrees into two. You get 45, 45. Okay. So we use this to define the Fowler's brothers. The semi-Fowler should not go, the head of the patient should not cross this middle line. Okay. So we can create your bed like this. Okay. Then your head. Okay, your head will be something like this. Okay, yes. So there's over here. Okay, so that is it. To semi-foulest position. The foulest position is what? Between this and that. Divide this last two into two. So 60 to what? 45 to 60 will be the semi-foulest. Sorry, the foulest. And the high foulest will go here for the asthmatic guys. Okay, yes. So we want the patient to feed. We can go as low as 45 or 30. Aspiration patients, we are preventing aspiration, or we want the respiratory support. People who need breathing support and feeding sometimes can go what? The foulest. But we want people to sit upright. Significant distress in what? In asthmatic COPD, ARDS, all these guys. Significant respiratory distress. Okay. Trendelenburg with the head lower than the feet. So if this is supine, if you don't know the normal, you can't know the abnormal. So this is supine. The head and the leg are in alignment, the same flat surface. Let me lower the end of the bed like this. Okay. So the head will come down like this, and the leg will be up like this. This is what we call the Trendelenburg position. Why do we do that? We do that sometimes for venous return, and also sometimes we are doing some abdominal procedures. We don't want the intestines to come up. So we want the intestines to go up, come down. We want it to go up like this. Trendelenburg position. Okay. So specific procedural indication. Then reverse. Now your head will be up and your leg will be down. Okay. The reverse Trendelenburg. Why do we do that? We are doing that for some selected GI procedures, neurological procedure, yes. So we are doing a bare hole, a craniotomy. We don't want the heart to pump a lot of blood. So the anesthetist will give medications that will lower the blood pressure. That is number one. Okay. And two, we will position the patient so that the arteries will struggle. They will have to fight with gravity before they push blood to the brain. Because the doctor, the surgeon is doing what? Craniotomy. They are doing a repair, a rupture, okay, of maybe all this stroke, a ruptured vessel. They are repairing it. You don't want a lot of blood in the head. So let us put the patient in the reverse Trendelenburg position. Okay. So the exact angles can vary somewhat by facility and equipment. So Nclex is usually more interested in the physiological response. If you put a patient in this position and the blood pressure and the heart rate are crashing, you should not say because of your procedure you are keeping the patient there. You need to reverse. Okay, that is what it is saying. Yes, if you those of you who work in theater, they will see it a lot. Sometimes we position patient, then we stop the surgery, we reposition. So the foulest position, you see pictures like this. Okay, the semi-foulest, you see it like this. Okay, and the high foulest, you go like this. Okay, yes. So it elevates the head of the patient and the upper torso, the upper chest. We do that to help what Elevating of the head helps reduce pressure on the abdominal content, okay, against the diaphragm, and generally allows better lung expansion. Yes, so that is why. So if you raise the head up, the diaphragm has more room to expand and contract. And that will help you with breathing. That is why asthmatic patients, people who are eating, eh, you are eating, you are eating, you are eating, you are putting food in your stomach here. Your stomach will be becoming big, big, big. It will put pressure on the diaphragm. Okay. So when we put you in this position, the stomach will drop down and the diaphragm will have more space to breathe. Okay. So, common situations we put this patient in: respiratory difficulty, feeding, aspiration precautions, cardiac conditions, okay, and post operative care. We have 10 minutes to leave, so I'm not going to waste your time. Now, the high fowlers, you think about what breathing difficulties. Okay, so we already know the physiologies. Yes. So, a clinical scenario is that a patient with acute pulmonary edema has a respiratory rate above 30. This is a serious and a critical condition. Respiration rate. Saturation has dropped to 984. This it means the patient is really struggling to breathe. More effort here. Okay. You heard crackles and the lower lungs. I should tell you there are a lot of fluid in the lungs. Crackles. Severe dyspnea. Which immediate position is appropriate? You say the high phallus or the upright. Don't lay this patient flat merely because they want to assess them. No. So over here, you put them in this position. When the lungs are struggling, positioning itself can be an immediate intervention. Okay, good. So let's look at this. We have 9 minutes. The autopnic. The medical name is Otopnic, but when you go to the market, trade name or the simple name or the guy name, people say it is tripod positioning. Okay, the tripod positioning. So the tripod positioning, if you want to make a triangle here, okay. So we look at, if you want to use the arms, we look at this one arm here, one elbow here, and the head like this. Okay. Or if you want to use the legs, we have one leg here, another leg here, and the arms or the head will come down. So still making your triangle position. This one create a base. Your chest will expand, so the lungs can expand. The diaphragm will have their space. The abdominal organs will drop down, so they don't press on the diaphragm. And you are leaning forward, that will expand your back. So if you are looking at me now, lean forward like this, it will expand your back. We sometimes use this for lumbar puncture. Some patients too, when they cannot breathe well, they sit in the tripod position. The shoulders are well relaxed. The patient is sitting comfortably. Okay. The head is in the neutral position with the neck, and the arms are supported. Some people they will put their arms on their elbow, their thighs. But this patient is lucky; he's having a bedside table, so he put his hands there. Okay, we call it what the orthopnic. If you don't understand orthopnea, Nclex will not write orthopnic for you because they know when they write this, you know the answer. So you go and you see what tripod position. You don't know what is tripod. How can you relate tripod with airway, respiratory system disorder? Okay. So these are the things you should know. Okay. These are the things, the little things you should know. So we can use positions like this for people with COPD exacerbations. Okay, somebody who is having COPD, but the condition has triggered again and is having serious symptoms of COPD attack. Yes, asthmatic guys, we can still use this one for them. People with respiratory distress, okay, ARDS. If a patient is naturally leaning forward to breathe, don't immediately force them to lie down. Eh? You see, those days when a patient come with asthma, they will be struggling. Okay, yes, they will be struggling to breathe. Then you see the nurses, they will put them down. Ah, please lie down. We are passing IV free, IV. Lie down. We are, oh God, you are killing the patient. Every stressed and dying patient who has not yet lost his consciousness will assume a position that physiologically suits them. So if the patient is lying, somebody is complaining of severe abdominal pain, they are lying at a position that will give them comfort. Don't change their position. Okay. It is a physiological position they have assumed. So a COPD patient who has come to the OPD and sitting down on the bench in a tripod position and doing, okay, don't go and say that, please, I have a bed for you in the emergency room. Come and go and lie down flat. You are killing them. Okay. Yes. So if the patient is naturally leaning forward to breathe, as a nurse, don't immediately force them to any position or supine position for your convenience. No. Okay, good. Then we have feeding position. Those of you who work in care homes and other stuffs, feeding, they can sit. Feeding. Avoid these positions. Don't let them recline back. Okay. And don't let their head also tilt back. And don't let them lie flat. All these three positions facilitate aspiration. So the food will now climb from their stomach and enter their airway. Okay. They should cross that 45 degrees, enter into these zones and feed nicely. Okay. So this is positionings that we are doing. It helps what? So food should go down to the esophagus, not the trachea. Okay, yes. Entra feeding. Entra. This same aspiration principle applies to tube feeding. Let me say entra. Okay, feeding. So, what are the ways that we can see? Oh, I did not add this picture. Dang, I downloaded it. Okay, so we have several ways you can do entra feeding. Okay, either through the mouth, so enteral feeding, you can do. I think I have a simple. Don't worry. So you can do NG tube here. Okay, NG tube here. If you want to do it manually or connect to a machine, or you can do to their stomach directly as peg tube, peg feeding. They are all enteral feedings. You can do to their small intestine as through what the jejunum, IJ, the ileum and the jejunum. Okay. Yes, this is what we call entra. Okay. Entra feeding. Yes, it can also pose. So all these ones should be in these positions. Okay. Yes. So head of the bed elevation is commonly used during enteral feeding unless contraindicated. Why? Because regurgitated gastric contents can enter the respiratory tract as aspiration. So Nclex will come. A feeding tube does not eliminate aspiration rate. The fact that he has a feeding tube does not take away the risk of aspiration. Positioning is very important. Okay. A patient with stroke who is having dysphagia, difficulty swallowing, you always have to assess any stroke patient you get, assess their swallowing, okay, swallowing, the gag reflexing, hmm, before you give them any food to eat. So sometimes some small, they can you can tell them to swallow saliva. You can give them some small water, okay, for them to swallow. They can never hide. Eh? They can never hide. If the patient is conscious, listen to this. If the patient is conscious, he or she can never hide difficulty swallowing unless they are unconsciousness. So unconsciousness, we call it silent dysphagia, okay, or silent aspiration. So what are the signs that will tell you if you give a conscious patient like you and I who is having stroke water or anything to take in their mouth, they will cough when they are eating. It's a sign that no, this guy, I can't let you eat solid food or foods that can choke you. Okay, they will choke. Some of them will choke. Okay, some of them too. We call it the gargling voice or the wet. When somebody is talking, you can hear that in the throat there is some water. There's some water there. We call it the wet voice. Okay, the wet voice. Then some of them do pocket food in their cheek. Okay. Some will be drooling, drooling. So all these signs will let you catch them that no, you did not pass the swallowing assessment. Some will be having respiratory symptoms. Okay. Yes. So there is an Nclex scenario here. A patient with recent stroke receives a small tray before swallowing safety has been established. What is the best action? Okay, you have two things to do. They are the kitchen guys, food and nutrition. They brought food on a tray, and you also have to do your swallowing safety. Which one will you do first? Best action. Do not begin swallowing. Do not begin feeding until swallowing ability has been established. So in stroke, we always say that what swallow. Remember, stroke, stroke start with S. Swallowing start with S. So in stroke patients, when you see this question, it's a trick I'm showing you. You not see it in any book. So the S and the S. Never put anything in the mouth for the patient to swallow into the stomach until you know the swallowing ability of a stroke patient. That's it. So the kitchen, the wife, the husband, the children can bring the nicest food the patient wants. Until the patient, you the nurse, you do the swallowing checks. Okay. Never put anything in the mouth or give the food for them. Okay. So do not begin feeding until swallowing assessment has been done. You are preventing complications. Unconscious patients should always do the sideline or the lateral positioning. Okay. Yes, we want to protect their airway. So, unconscious patients with a lot of secretions, think of what? Putting them on the lateral position with airway protection. Protect their airways. Okay. Recovery position is good. You went and met somebody unconscious by the roadside, put them in the recovery positioning. Recovery positioning, okay, is very, very important. The recovery positioning. I can show you picture. Let's continue. Without, I'll update this. Okay. So I'll update and put the picture there. Without, so an unconscious patient person without suspected spinal injury, that is the only complication, contraindication to this position. Is commonly placed laterally to help maintain airway patency and facilitate drainage. Okay, so we have, let me see, I think I need to show you this position. Recovery position. Please do it for anybody you meet lying by the roadside. Okay, a car has knocked somebody down and the driver has run away. The nurse should put the patient one. You see how the head has been tilted. You see how the head has been tilted. It will facilitate drainage. The neck and the head is in alignment here, plus this leg, and this one too is moved a little up, and the hands are here. It will help the lungs to expand and contract nicely, and any aspiration from the stomach will come straight to the mouth and outside as drooling. Yes, so somebody suddenly collapsed. If you do and they have a pulse and they are breathing, recovery position. If they don't have a pulse and they are not breathing, CPR. You don't do CPR in this position. So these are some of the things that you should know. Okay. If you suspect any injury, yes, now airway protection must be balanced against spinal alignment. Okay. Do not casually twist the head of the patient. Use appropriate spinal precautions, cervical collar, and coordinated movement when repositioning. So, in the ER I work, anytime you come in front of the ER, there is a stretcher with a cervical collar on it and with a backboard on it. Okay, always there, waiting for this type of patients. Okay, yes. Somebody with increased intracranial pressure. Increase intracranial pressure. This is extremely high because Nclex, you meet a lot of people, questions like this. So for many patients with increased ICP, positioning includes the head of the bed approximately 30 degrees. Don't go higher. Don't go higher. Okay. And head and neck maintain in what? A neutral alignment. Why? The objective is to promote cerebral venous drainage. You don't have to keep more blood going to the head. So you facilitate what? You facilitate venous drainage back into the heart. Okay. Yes. Don't go and do a Trendelenburg position for somebody with increased intracranial pressure. You let them die. Okay. They will let the blood pressure and the pulse crash. Okay. So guys, let's end at 12 tomorrow. No, tomorrow. I don't think I will meet you tomorrow, but Saturday we will meet. Okay. Saturday we have a meeting. So tomorrow is, if I'll meet you tomorrow, I'll let you know. But Saturday is a must. We must finish this. Okay. So guys, thank you so much for thank you so much for the lectures today. Okay. Learn everything. You need to learn everything. Don't waste much time. Okay. And take notes of every important question you see. Okay. Right. So tomorrow when we meet, We will finish the basic, we will finish the head, the positioning. We have so many things to learn with positioning, all this lumbar puncture positioning. We've got these ones there. We've got more pictures. Okay, some of thoracentesis. Okay, we do these ones. Okay, so many positionings and their complications. So prone positioning, why we do it, a clinical case like this. Okay, so we do all those ones. Okay, yeah. So don't miss out. Don't miss the class. It is going to help you a lot. The log rolling for those with spinal injuries and all those stuffs. Okay, so we learn all those ones. Then seizure, somebody is having seizure, how to, somebody is vomiting, okay, somebody is in shock, okay, clinical condition, somebody is having air embolism, what positioning is good for him. You are going to give enema, you put them on the sims, you ask yourself, where should I put when I push the medication into the anus? Should I go left or right? Uh-huh. So that is it. Because some people will say that I gave enema, but the patient did not poo poo. Why? So you have to know the anatomy of the large intestine. Okay, that is it. Okay, rectal examinations, NG tube positioning, cardiac patients and their positioning, pregnancy patients and their positioning, delegation, you the nurse, okay, are you going to delegate someone to positioning or not? Then positioning and tubes and lines, okay, then chest tube trap, chest tube positioning and all those ones. Is positioning dynamic? Okay, we also learn that one. Then we finish. This is the elite table for you. I've drafted it. So every condition and the position you should go. Then the Nclex trick, which position is best? So these are the questions you go through. Which organ is failing? Okay. If the lungs are failing, which position should I go? Okay. So you've seen the body organ failing. Your aim is to save the organ. So that will be your focus. Your goal is what am I trying to accomplish to expand the lungs? So if you want to expand the lungs, which position should I put the patient? Eh? Somebody has hit the head on the floor, bam, is bleeding, internal bleeding, having confusion, and all those stuffs. Okay. Which position will you put the patient? What organ are you protecting? Okay. The next question, what could save this position? What could worsen this position? Are there any special restrictions I must make? Then after that, you look at some questions we go through. Okay. Then we say bye-bye to positioning. Then we go to part 3, mobility transfer, ambulation, canes, walkers, and crutches. So we have a lot to learn. We will finish all these ones, helping somebody to transfer from bed to bed. Okay, we are using the gate, but somebody is having orthostatic hypotension. What are you supposed to do? You are using the gate belt, how you should go about it. Okay, all these ones we will go through transferring with wheelchair. Okay, and 2 people assisting with transfers, 1 person assist. What are you supposed to do? So basic nursing is terrible. In nursing training, we used 1 year to do basic nursing. But in Nclex, we can use, let's say, 3 days or 4 days to finish everything. Okay. Yes. So a patient is falling. What are you supposed if it is 1 person, you are assisting the patient to go to the bathroom and start falling. what you are supposed to do. If you are two people, you are assisting the patient to bathroom to fall. What are you supposed to do? Okay, so one assist and two assist. You assist them to fall. We call it control for assisted fall. Okay, so these are the things you are supposed to do. Assisted fall. Okay, yes. So all these ones you are supposed to. Then cane using of canes, how they should walk. Okay, if somebody is using the cane as a stick, if they are climbing the stairs, how they should go. Okay, all these ones you're gonna learn it. Okay, somebody is using the cane for the staircase to climb and to descend. Okay, yes, so all these ones. Never miss a class. You are using a walker. UK people call this the Zimmer frame. Okay. US they call it walker. Okay. So you have to use the walker to mobilize the patient. So all these ones are there. Then the crutches, how to measure the correct size for crutches, how to place your hands, and how to position it in your armpit. So these are the steps we go through: the 2 point, the 3 point, and the 4 point gate. So they are all there. Okay. If you don't know, don't miss this class. Yes. Then we also look at, we have a lot to learn. Learning is good. Okay. Yes, the tripod, 3 point gate. So that is it. Using a walker on a flat land. So simple and easy. Okay. Using a walker, okay. Using a walker, okay, on a flat land. Then we can use a walker on a staircase to climb and to descend. So to climb and to descend, to climb and to descend. Okay. So these are all the things you should know. Okay. Then range of motion exercises. Yes. So if your hospital, we have a physiotherapist, they will come and do this work. But if they don't, you the nurse will do. So range of motion exercise to prevent contractures, to prevent muscle immobilities. So you should help patients with mobility. These are all basic nursing. Range of motion exercises. Okay. Yes. Internal rotation, external rotation, all these ones. You should know how to do it. Those of you who will be working, a patient has come with what, deep vein thrombosis. Are you supposed to do range of motion exercise for them? Are you supposed to mobilize their limbs? Are you supposed to palpate their legs? Okay. Deep vein thrombosis, unilateral swelling. You see somebody varicose veins all over. So you see a clot is inside somebody's leg, severe pain. The red blood cells are breaking down. Yes. So what are you supposed to do to help them with positioning? Then we have the plantar and the dorsiflexion and the plantar flexion, the foot drop. Okay, guys. So how what you are supposed to do to help them? They're having a nervous problem, foot drop. Okay. So mobility and position, these are the areas that they would tell you, they will trick you a lot. Okay, they will trick you a lot. Then we go to nutrition, feeding this fragile. So guys, let's end here. Thank you so much. Bye bye. We meet another time. Okay. Thank you. Thank you. Thank you. So bye bye for today. We've got a lot to learn. A lot to learn. Okay. Bye bye. Bye bye for now. Okay. All right.